Good morning, everyone. Welcome to day 3 of the 2022 RNDS. This morning, we're going to get started with a presentation from Dr. Lana Harder. Lana is a full professor of psychiatry and neurology at the University of Texas Southwestern and Children's Medical Center in Dallas. And she is kind of the pioneer in this work of psychology and cognition in children and in people with rare neuroimmune diseases. And the title of her presentation this morning, the first one, is Impact of Rare Neuroimmune Disorders on Cognition, Depression, and Quality of Life. Thank you for coming.
Thank you for that kind introduction, and thank all of you so much for having me. I only wish I could be there in person with everyone. So as Dr. Levy mentioned, I'll be talking about how rare neuroimmune disorders show up in daily life, essentially. So thinking mostly today about cognition, mood, and quality of life. I first want to acknowledge the patients and families impacted by these rare diseases that we're talking about this weekend. Without their stories, it would be very difficult to do the work that we all do together to try to understand how these conditions impact daily life so that we can intervene and offer treatment plans to address those challenges. So I really wanted to start with that acknowledgement, as well as acknowledging SRNA, and again, thanking you all for having me. We've had a long-term partnership at 10 plus years, and I always love to be a part of any of these programs where we can share the information that we're learning all the time. I also want to acknowledge my team in Dallas. They make coming to work on Fridays for clinics so much fun, and it's the bright spot of my week. So I want to acknowledge each of them. I've learned so much from working alongside this group over many, many years. I like to start out just by mentioning the role of neuropsychology. I frequently get questions about what neuropsychology is, and so I want to be mindful that not everyone has encountered a neuropsychologist or knows about our field. The most succinct way I've learned to describe this is to describe it as the science of human behavior as it relates to central nervous system function. So you'll hear neuropsychologists talk a lot about cognition that you can see in this first image and how it relates to brain function very directly and specifically. We also are concerned with behavioral functioning, emotional functioning, and aspects of quality of life. Fatigue is a big one that we focus on, and that will be the focus of this discussion for this morning. So I wanted to just set that as the context. When I think about the work that I do, and I work with trainees and talk about it, one of the first places we're starting in our institution is the medical condition. So what I have here is an MRI of a teen with multiple sclerosis, and we'll pretend that this is the same teen in this stock photo that I have of a teen in a classroom setting. So the idea here is, we want to understand how a condition like MS impacts daily life or shows up in daily life, like in classroom learning, since that's where our teens spend most of their days. The situation is much more complicated than that. So there are a lot of things we're trying to understand at the same time to also recognize that many other factors impact how any of us show up on any given day. And so I think about this especially when a patient is coming to see me. I want to understand their background going all the way to gestation forward, understanding when they've had a medical event, what age were they, is the disease or condition acute or chronic, and a whole host of other factors, certainly the family and school environments, how they are coping with everything that they're managing and so forth. Importantly, we want to know what supports they already have in place, and we want to look at what supports we might be able to add for them. So this is kind of a snapshot of what I'm doing at an individual level when I evaluate someone. I also identify as a clinical researcher, and so I definitely want to acknowledge the difference in those roles. So when I'm in there as a clinician, I'm really focused on that one patient at a time, working with my team to create these tailored evaluations and recommendations for that one person. When we talk about research, which we'll do today, this is more typically we're thinking about diagnostic groups. Maybe we have a set age range. For me, that's going to be the pediatric age range. We're going to have some questions, hypotheses. These are things that usually arise as I interact with patients and families and hear their stories. So I generate questions about what it means to be an individual or to have an experience with one of the conditions that we're discussing. And I'm looking very much at the group level. So as I describe some research findings throughout the morning, that's really where I'm coming from. But the results of those group studies can help us extract clues about how we might help those individual patients who come to see us. So over the years, we've thought a lot about how can we compare groups in our clinic to better understand really each of those groups. As you've heard this weekend, I think MS is a much more common condition, especially in adults, not so much for children, but is more studied, it's better understood, whereas a lot of the conditions we talk about are rarer and so a little bit harder to study. So initially when we were thinking about good comparison groups for just first studies that we were doing as a team, we wanted to look at this well-established MS, brain-based medical problem as it compared to transverse myelitis, which impacted the spinal cord only. So early on, we did that comparison, and we hypothesized that those with MS would have more difficulties with cognition and school problems. And what was unexpected to us is that the rate of school problems, which is something we look at a lot for kids, was equivalent for those with MS versus TM. We also saw that there were some cognitive problems we had not anticipated for individuals with TM. So I would say that really was a pretty defining moment, and at least in my research narrative, that I wanted to take a turn and look at some things in a different way, and I'll be describing that. We did go on to publish a paper on cognitive functioning in transverse myelitis. What you see in this table is the list of cognitive domains that we evaluated, along with the frequency of problems or impairment that we found. So you can see, again, this was really unexpected for us because we know that TM doesn't affect the brain directly. Now, we also noted there were higher rates of fatigue noted for our patients with TM, and these were pretty impressive to us. This left us with a number of questions. So it's a great thing about research. You may answer one question or two questions, but then you end up with probably many more questions than you had before. So we did wonder because in our early study, we had pretty small sample sizes. So we wondered if there would be differences in cognition with larger sample sizes of MS and TM. As I noted in the last slide, we really wanted to better understand fatigue. That stood out to us in that TM and cognition paper. So we wanted to know if fatigue was playing a role, and also if mood impacted cognition. This was a question that was coming up over and over in conversations we would have in clinic, at our camps that we would attend, and events with our community. So we'll come back to these questions in a moment. But I started to think of MS as a control in rare disease research. So knowing that we, again, have established a lot of knowledge about MS, primarily in adults, but some in pediatrics, I was very curious to continue to use this as a comparison group. So an important point that I think we've seen over and over in our research is that cognition, mood, and fatigue are often interrelated. So when we run our statistical analyses, we see that these things are significantly related, and that when you treat one of these issues, you may get bigger bang for your buck, because then you are also treating some of these other interrelated difficulties. So I just want to mention that. I think that's a really important point that I'll come back to at the end of our discussion today. This also got me thinking about who else has compared MS to our rare neuroimmune conditions. When I first started in the clinic, we did not know a lot about cognition and NMO. In fact, everything I could get my hands on at the time said there's really relative sparing of the brain, so didn't really go there in talking about cognitive problems. But as you can see, some studies have popped up since that time. I don't expect us to digest everything in this slide. This information is really here for reference, but what I want to sort of highlight here is that in these studies, they found no, in some of the studies found no differences between NMO and MS when it came to cognitive function. Again, these are adult studies, so but it's all we had. So as a pediatric clinician, this was very meaningful to me because I was very aware of, again, how well established it is that individuals, a large subset of individuals with MS may have cognitive problems. So then to hear that there's no significant difference with those with NMO really, got my attention and made me think about this population differently. And I will note, we screen all of our kids in the clinic cognitively, regardless of their diagnosis. So we were already kind of on top of that. We use the screeners to then determine if we would do additional assessment. There was some research looking at pediatric MS compared to ADEM, a very small sample size, 9 in each group. What they did see is what we might predict based on the nature of MS being a chronic condition where you accumulate disability over time. But those with MS demonstrated more impairment on our cognitive domains. Generally, those with ADEM showed normal levels of cognitive function, but there were weaknesses identified in complex processing. So this is kind of what we knew as it related to MS compared to ADEM. So going back to these questions and thinking again about MS compared to TM, my dissertation student, who's now Dr. Cole Haig, who's up in Boston now, he did this study, took this on and really looked at several of those questions I just shared with you. So as you can see, his title was reflects that he looked at the role of fatigue, depression, and other clinical factors in determining cognitive status in pediatric MS and TM. So in order to go down that road and think about those questions, I want to set the stage and talk about what we do know about MS and fatigue. It's sort of hard to overstate how debilitating fatigue is. It's one of the most commonly reported symptoms and often the most debilitating symptom as described by those with MS. So as many as 75% of adults experience fatigue in the context of MS. We know that it impacts quality of life. And more, our literature has grown to show us that this is true for pediatric patients as well, that they endorse a great deal of fatigue. And that research is still kind of developing and expanding. In terms of MS and depression, we know that the lifetime prevalence for depression when you have MS is quite high at 50%. There's a lot of discussion and information we've learned about the role of the inflammatory process on the brain as a biological basis for some of those symptoms. And then we know that about half of those with pediatric onset MS meet criteria for a psychiatric diagnosis, and many of those are the internalizing conditions like depression and anxiety. When it comes to cognitive problems, the estimates that we have there, about half of adults with MS will have cognitive impairment, about a third of those with who have pediatric onset MS. So in Dr. Haig's study, he really wanted to evaluate and compare fatigue and depression symptoms between groups of pediatric patients with MS and TM, and to explore the relation of fatigue and depression to cognitive status. So I want to give you some high-level findings that I think are really important. First of all, his sample, this is a pretty robust sample when you think about, again, the rarity of pediatric onset MS, as well as we know for TM. So 67 with MS, 53 with TM. And the measures used, we had data from a cognitive screening battery for everyone in the study, as well as caregiver and patient reports on mood, and we focused in on the depressive symptoms in particular, also looking at quality of life and focusing in on that which was related to fatigue symptoms. And that's in 3 areas: general, sleep, rest, fatigue, and cognitive fatigue. So key findings for fatigue, there were no differences when we ran the statistical analyses between MS and TM groups for all of the areas that I just mentioned. Another way that we look at this is we compare to the normative mean, just to see if the groups differ significantly. And in all areas of fatigue, both groups showed statistically significant worse fatigue. So this is a really important finding. Again, knowing that fatigue is one of the most common, most debilitating symptoms associated with MS, to then learn that there really are not differences between MS and TM, I think really in certain ways validates the symptoms of fatigue in transverse myelitis, which is something we've wanted to better understand over the years. I think if we were to, showing this to folks who experience TM, they would probably not be very surprised by these results. I think it's always good to test those hypotheses and have the data to support this. And then this table here just shows the frequency of elevated fatigue across those groups. So what you can take away from this is general fatigue is quite comparable between MS and TM when looking at frequency of difficulty. And then you see some differences there with sleep and rest and cognitive fatigue, where that's a bit more pronounced or more common for MS, the MS group. But still, when you ran the analyses, you did not see a statistically significant difference. When it comes to symptoms of depression, and I want to emphasize these are not diagnoses of a clinical depression. So we were just looking at symptoms and symptom elevation. We saw no differences between groups, but we also saw no differences for the normative mean. So, meaning that the symptoms and kind of frequency of symptoms were not different than what we would expect in the general population. And you can see about a quarter of those with MS and a quarter of those with TM experience elevated symptoms of depression. So this question comes up a lot with my colleagues, with the patients and families I work with. How do we know if we're looking at depression symptoms or fatigue? And I want to say it frequently is both, and that's perfectly fine. These things co-occur, but I do think it's important, and this is a role neuropsychology frequently plays, to look at kind of how to tease these things apart. So what is overlapping? Well, changes in sleep, motor slowing, loss of energy, diminished engagement in activities, and diminished cognitive skills like the ability to concentrate. These are things that we can see in depression or in fatigue. When we think about other things to consider, how might we separate these to better understand what's going on? The reason for wanting to separate these two, importantly, is this would have different implications for intervention and treatment. So of course, for depression, we would be looking for a depressed mood and one that's lasting. I would also say feeling sad, empty, hopeless, maybe seeing weight changes, motor agitation, feelings of worthlessness and guilt, recurrent thoughts of death and dying. For fatigue, feeling tired often leads to the reduced engagement in activities, and we also think about kind of feelings of physical weakness. So these are just some things that I think about when I'm trying to determine, is this depression or is this fatigue, again, or is it both? So in Dr. Haig's study, going back to that, when he looked at cognition, we were able to evaluate rates of cognitive impairment. And we did see a significant difference where a cognitive impairment designation was much more common for individuals with MS, which makes a lot of sense given the brain-based lesions in MS and the chronic nature of the condition. And then those with cognitive impairment were more likely to have elevated general and sleep rest fatigue problems. So that's an association that's really important to point out. So Dr. Haig also had the question, what factors predict cognitive status in MS? So what would predict if you were in the impaired versus non-impaired group? And so we created this model where we looked and considered all of these factors. So a person's diagnosis, levels of fatigue, levels of depression, age and onset, time since onset, and physical functioning. And the one thing that stood out that was that's highlighted here are symptoms of depression. So that increased the likelihood of cognitive impairment. This is a finding that we've seen across other studies and in other populations as well. It was very interesting to see that be the one thing that stood out in a significant way. So what does all of this mean, and what are some of the takeaways? I think just broadly speaking, we are aware that those with CNS demyelinating disorders are considered to be at risk for neuropsychological difficulties. That's a very broad statement. And I will mention that not all are affected. I work with plenty of patients that do not report these things, that don't have difficulties on our testing. So there's a lot of variability. And I think that's what really underscores the importance of that individual evaluation. We can describe our research findings and what we see in a cohort, but we also, kind of at the end of the day, really want to know about what's going on for the person in front of us. Having the research, however, helps us realize that there is that risk, and so we want to explore that. That's why I'm in our clinic, is to conduct those screeners to see where the problems are and who may benefit from additional testing and more treatment planning. So we also think a lot about this, that when we see co-occurring symptoms, that if we address one of those, we may also have an added bonus of improving other areas of function. So as I think I've said many times now, we really just want to tailor our interventions to meet individual needs. And I want to talk a little bit about that. Another question I get a lot is, how do you know if you or someone you know should be referred for our services? And so I think the people that are in the best position to evaluate that are the individuals themselves and those who are closest to those folks, because what they can evaluate are the symptoms that we've been talking about. There could be changes over time. So one example is there could be a person, maybe this is resonating with someone in the audience for themselves or someone they know. Maybe the change or the observation has been mood changes over time. And so it might be a good time to explore assessment and treatment options for that. It could also be someone who's always struggled in a given area. Maybe it's paying attention or reading or kind of insert whatever the problem is. There are plenty of developmental problems or problems that had an earlier onset that maybe have gone unaddressed, unassessed, or untreated. So it doesn't have to be that there's been a change, but maybe it's been a long-standing struggle. In either case, what's important to really think about is, how is it affecting daily life, school, work, interactions with friends, family, getting out to do activities. We think of that as the functional impact if it's creating a barrier to daily life. And so what we would say is, if there are concerns, speaking with a primary care physician, a neurologist, members of the care team could help point you in the right direction for pursuing those services. And just a note about neuropsychology, we have a really vast network across the country and even across the globe. So we are out there and can be found for these services. One thing I have the privilege of saying to my pediatric patients, which goes a really long way, is I'm not a medical doctor. I don't do medical procedures, and that's usually a huge relief. So I like to kind of paint a picture of what this looks like. Some people might be hesitant to seek services, but knowing a little bit more could be helpful. So it's a lot of question answer. It's collecting background information, reviewing of the medical record, and pulling in other information as needed. And we frequently ask teachers for information, parents or other loved ones who know the patient best. We may be expert in neuropsychology, but those around the patients we serve are really the experts on those individuals. And then we are looking to identify primary problems. Sometimes there's a diagnosis. And for me, again, that's not a medical diagnosis, but examples would be ADHD, dyslexia, autism, a whole host of things, maybe depression. We are really most looking for strengths and weaknesses in that individual. We all have them. We're human beings, and that's how we're made. And so we really want to understand those strengths in order to leverage those to address weaker areas. From that, we create tailored treatment plans, including a plan for follow-up. And then I just want to say a few things about wellness. I think this is important for all of us. I think that we have learned more and more over the years about what helps when we're struggling. There's a lot of great research. We talked about depression today, on therapy, on medications for depression. When you pair those, you tend to get even the biggest improvement. We know lifestyle factors are really important for addressing many of the things that we talked about today: getting sufficient sleep, exercise, nutrition, having social support, a social circle. All of these things go a long way for brain health and overall wellness. So I want to mention that. I can't emphasize this enough: caring for the caregiver. And so remembering to take care of yourself before you take care of others. Just like we hear when we're on an airplane, we need to put on our oxygen mask before we help someone who needs that assistance. And then very importantly, mental health is health, and it's for everyone. And so for anyone listening to this with or without a medical condition, make time for mental health each day. I just want to also mention, in terms of supports, things that build us up and help us, is being here at an event like this, having the SRNA community. We are stronger together. And so I think programs just like this are what it's all about, and how we can come together to improve our own situations, and that for our community. And just as a final slide, some of my favorite scenes here, but I want to thank you again for having me. I was noting the time and think I just barely hit it right at 11:30 here, 9:30 for you all. Happy to take any questions if there's time, and I'll be talking again in another hour or so.